Hi, everybody. Thank you so much for joining today. We'll get started right at the top of the hour. Thank you for joining. We'll be starting momentarily. Thanks for joining. We'll start the webinar momentarily. Thank you for joining. We'll start the webinar momentarily. Thank you so much for joining us today. I'd like to welcome everyone to the STS webinar 2025 webinar series. Today's webinar is titled Appropriate Lung Cancer Staging and Diagnosis, supported by AstraZeneca. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce our moderator for this evening, Dr. Ian Bostock. Dr. Bostock, let me turn it over to you.
Good evening, everybody. Thank you so much for joining us for this webinar. We're excited for the information that we're about to share with you all. My name is Ian Bostock. I'm a thoracic surgeon at the Miami Cancer Institute, and it's my pleasure this evening to introduce our first presenter, Dr. Eric Singy from MD Anderson Cancer Center, who will be giving us the medical oncology perspective, what every surgeon should know before the knife, molecular testing, biomarkers, and neoadjuvant considerations. Go ahead, Dr. Singy.
Thank you so much, Dr. Bostock. Let me just put it in the correct presentation view. Well, thank you to the organizers for inviting me tonight. I'm really excited to talk about the medical oncologist perspective in early stage non-small cell lung cancer and offer my humble thoughts. I have a lot to get through in just a few minutes, so bear with me. These are my disclosures. So first, I thought I'd talk about molecular testing in lung cancer and how it's truly essential for our patients with early stage non-small cell lung cancer, not just late stage. Before we get into that, really our thoughts of lung cancer have evolved quite significantly over the years. So traditionally, we thought about lung cancer as a single disease, and then we became more sophisticated. We started to think about non-small cell lung cancer versus small cell lung cancer, and then we thought more about the histology of non-small cell lung cancer, squamous versus non-squamous. Then we had a layer of molecular pathology where we started to think about actionable genomic alterations. And of course, we think about protein expression, including highly important PD-L1 expression to help guide our therapies. And so what we've learned is that lung cancer is not just one disease, but many. And we define these different subtypes of lung cancer using biomarkers. So what are biomarkers? Biomarkers, they can be diagnostic, they can guide disease diagnosis and classification. They can be prognostic, where they inform clinical behavior in the natural course of disease. And they can be predictive. They can help us predict clinical response to specific therapies. How do we get information about these biomarkers? Well, we do it through molecular testing. So what is molecular testing? Really, the gold standard of molecular testing is done on tissue biopsy. So we're so grateful to our colleagues in interventional pulmonary, in interventional radiology, our thoracic surgeons, everyone getting us tissues so we can help perform molecular testing. And there's different components of molecular testing. So we can have DNA sequencing, which is looking truly at next generation sequencing panels to find these aberrations, such as insertions, point mutations, and deletions. We can have RNA sequencing, which helps us find more of the fusion abnormalities. So some of the fusions you may have heard include ALK, ROS1, RET, NTRK. And then we also have immunohistochemistry testing, which helps us detect PD-L1 status. So clearly you can see there are multiple definitions of molecular testing for tissue. And my take is really to do combined DNA and RNA sequencing for next generation sequencing, and of course include IHC testing. But there's also a liquid biopsy. Liquid biopsies, what this capitalizes on is that tumors can release cell-free DNA, and they do that into the bloodstream. And so you can get a blood sample to get the cfDNA and then use that for NGS or next generation sequencing. This can be rapid, non-invasive, and really helpful when it's hard to get tissue or have enough tissue for it to do tissue biopsy and molecular testing on. Of course, though, you have to acknowledge that the sensitivity is truly dependent on the tumor burden and cfDNA shedding. And so this is a really great test for stage 4 disease. The sensitivity, though, is still 70%, but it's not always great for early stage disease. It can't tell us about PD-L1 status. You need tissue. And a negative liquid biopsy could actually be a false result. And so I often think of a liquid biopsy as complementary, not necessarily a substitute for tissue biopsy. So NCCN guides us on who should be considered for molecular testing, and this is just stage 4 NCCN guidelines, and they've broken it down by non-squamous and squamous histology. For non-squamous histology, advanced stage disease, you absolutely need to be checking for molecular testing, looking specifically for all of the driver alterations. That's a category 1 recommendation, getting broad molecular testing and PD-L1 testing. Interestingly, NCCN says to consider molecular testing for squamous cell histology, but my takeaway is really truly for all patients with stage 4 disease, regardless of histology, if they have non-small cell lung cancer, please order comprehensive next generation sequencing. Of course, our focus for tonight is on early stage disease. And so what does NCCN say for early stage disease and molecular testing? What it tells us is that we need to absolutely be looking for EGFR, ALK, and PD-L1 status. However, my takeaway is also to perform broad molecular testing for patients even with early stage disease. One, because this opens up options for clinical trials for patients, and second, it can be highly informative in the case of disease recurrence in the future if this were to happen for patients. This is the reason why it's important to check beyond just EGFR and ALK. This is really showing you the incidence or prevalence of mutations in advanced non-small cell lung cancer. You can see we have a plethora of different targeted therapies matched to specific mutations, and we won't know unless we check. And so this is just stressing that point. Moving on from molecular testing and thinking about treatment options in early stage non-small cell lung cancer. As you can see, for decades, we were really using adjuvant chemotherapy, specifically cisplatin therapy based on the LACE meta-analysis, and that was our standard for almost 2 decades. And it really wasn't until 2020 where we started to think beyond and actually get approvals beyond chemotherapy for our patients with early stage resectable disease. And so you can see we now have many and several recent FDA approvals with a growing list here that encompass the neoadjuvant only setting, the perioperative setting, and then an adjuvant only setting. But with so many different options, particularly for patients with no actionable genomic alterations, how do you choose? And so before we get into that, just thinking about neoadjuvant versus adjuvant therapy. Really, there's benefits to neoadjuvant therapy. Us medical oncologists get excited. We get to give our upfront systemic therapy first. There's a potential to treat early micrometastatic disease, a potential for surgical downstaging. However, there are some negatives. There's a wait time, obviously, to start therapy due to screening and other things that need to be done. And we know historically that about 15 to 20% of patients will not make it to surgery for various reasons, not only disease progression. On the flip side, adjuvant therapy, if we pursue that, it allows you to get to the surgeons faster. They get to their upfront definitive therapy. You do get a postoperative sample where we can do all of our additional biomarker testing on and try to personalize our adjuvant therapy. However, there are negatives such as a lack of integrity of the immune system. So if we're using immunotherapy, are we truly delivering the best drugs at the best time for the most benefit for the patient? And we also know that by pursuing upfront surgical resection, about 30% of patients will not complete their prescribed adjuvant therapy. So these are my humble thoughts thinking about all of this together. First, I would say that a neoadjuvant strategy seems to be a better strategy than an adjuvant-only strategy for most patients with stage 2 to stage 3 resectable non-small cell lung cancer who do not have an actionable mutation, and I'll show you why. This is the data from the adjuvant-only study, the Empower 010 study. This was a phase 3 study where patients with completely resected stage 1B to stage 3A non-small cell lung cancer did have to receive chemotherapy. After chemotherapy, they were randomized to receive atezolizumab, which is immunotherapy for 1 year, versus best supportive care. And the primary endpoint was disease-free survival. What we heard about and led to FDA approval was that for patients that had PD-L1 positive disease, defined as 1% or greater, and they had stage 2 to stage 3A disease, we saw a clear disease-free survival benefit for patients that got atezolizumab after chemotherapy versus best supportive care. The hazard ratio was 0.66. This was exciting. But we just saw the overall survival data from this, updated overall survival data. And what you can see was that, unfortunately, it was not significant. The hazard ratio, yes, was 0.77, but you can see that the interval exceeds or crosses 1. So this was not significant. Now, for patients where we really selected on, for patients that were 50% or greater with a PD-L1 status, which we often call high PD-L1 expression, overall survival was positive. But what I'll caution you on is that this only represents about a third or even less than a third of patients with early stage disease. And so most patients are truly not living longer with an adjuvant-only immunotherapy approach, is what this has shown us. My second humble thought is that for now, if an actionable genomic alteration such as EGFR or ALK is present, upfront surgical resection should be preferred at this time, followed by adjuvant systemic therapy. So again, this is for patients with actionable genomic alterations. The reason why is because of the ADAURA study. So the ADAURA study looked at giving adjuvant osimertinib, which is an EGFR-targeted therapy, for up to 3 years after a patient had completed resection, surgical resection for their stage 1B to stage 3A disease harboring a classical EGFR mutation. And this was randomized to placebo. And we got really excited hearing about the disease-free survival benefit for these patients, which you can clearly see here for patients that took adjuvant osimertinib. And this also translated into a proven overall survival benefit with a hazard ratio of 0.49. And so with a clear overall survival benefit for these patients with an actual genomic alteration such as EGFR, this has really been my preferred practice as of this time. My third humble thought to leave you guys with is thinking about for patients with pathologic complete response after they've received neoadjuvant chemoimmunotherapy, there can be a strong reassurance now that adjuvant therapy may not be necessary for every patient, and I'll show you why. So this is the CheckMate 816 study. This was a neoadjuvant-only strategy for patients who were randomized to receive chemoimmunotherapy, so nivolumab plus chemo versus chemo, and then patients went to surgery. What you can see here and what we knew about a few years ago was that a Nivo plus chemo, so a chemoimmunotherapy approach in the neoadjuvant setting, clearly improved pathological complete response. Historically, chemo alone did a very poor job, about a 2% achievement in PCR. That has now increased to about 24%, which was exciting to see. What we were waiting to see was if this translated to overall survival, and we did see this just at ASCO this year in June of 2025 in Chicago. And we saw that there was a clear overall survival benefit for patients that got neoadjuvant chemo plus immunotherapy as compared to chemo alone. In fact, a 10% absolute overall survival benefit. They also looked at an exploratory analysis to see how the patients who achieved PCR did. How was their overall survival? And this was unprecedented to see that there was 5 years out, 95% of patients were still with us who had received neoadjuvant nivolumab plus chemotherapy. So that translates to a 90% reduction in risk of death by 5 years versus for patients who did not receive PCR, so highly significant. So that was a lot of information in just a few minutes, but my key takeaways as a medical oncologist on this Society for Thoracic Surgeons talk is that biomarker testing is essential, even in early stage disease. There are now multiple approved options for systemic therapy in early stage disease beyond chemotherapy alone, and informed and shared decision-making plus multidisciplinary involvement is absolutely key. Thank you guys so much.
Thank you so much, Dr. Singhi. That was an outstanding review of all the information right now. We're going to quickly move on to the next presenter, but we're going to have a time for questions at the end of the sessions. So our second presenter is Dr. Fabian Maldonado from Vanderbilt University Medical Center, and he's going to give us a pulmonology perspective, navigating the diagnostic workup, optimizing tissue acquisition and nodal staging before the OR.
Great. Thank you very much for the kind invitation. I'm happy to be here. I hope you can see my slides. Can you confirm that you do see them?
Yes, we do, Dr. Maldonado.
Perfect. Thank you so much. Great. Okay. I'm an interventional pulmonologist. I work in Nashville, Tennessee at Vanderbilt. I was tasked to talk to you about the management and workup of lung cancer, early lung cancer in particular, from the standpoint of the interventional pulmonologist. And so what I'd like to talk about today is how we think about optimizing tissue acquisition, nodal staging, but also diagnostic sufficiency for next-gen sequencing in particular, which you just heard is absolutely critical in our management of patients. These are my disclosures. And I also have quite a bit to talk about in 12 minutes, so I will try to get through it. I'd like first to talk about the rise of what we've decided to call as a community the oncopulmonologists, recognizing that Pulmonologists very often are the port of entry into the lung cancer journey for many patients. And we've had to start thinking not just about the biopsy itself, but how to optimize staging. And that is, of course, EBUS, bronchoscopy, but also PET scan, MRI, etc. And also optimizing efficiency in terms of patient throughput. I'll talk a little bit about the role of bronchoscopy in establishing the diagnosis, mediastinal staging, and optimizing specimen acquisition for next-gen sequencing, focusing on the most recent data we have available. What's very clear is that we have a big problem in the way we take care of patients in general. Right now, the lung cancer care is very fragmented. Patients are referred back to their primary care provider after an abnormal CT. Often from there, they go to the general pulmonologist who may refer to interventional radiology for CT-guided biopsy or interventional pulmonary. From there, they may get a biopsy, may need a repeat biopsy for EBUS staging, and then another biopsy potentially for next-gen sequencing. And that adds on and it takes a lot of time for patients to eventually get to treatment. Now, we know that time to treatment is very important in many cancer types. The data is a little bit, particular for lung cancer, primarily driven by the fact that patients who present with advanced stage disease are generally treated much faster. And so we have this paradoxical effect in terms of time to treatment data for lung cancer. Nonetheless, I think it should be intuitively obvious to all that the more time you're going to spend, the more likely you are to progress in your lung cancer, and that's not a good thing. It causes a lot of anxiety for patients if that's a good enough problem to tackle. We have great data from this wonderful meta-analysis published a few years ago, 20 years worth of data, over 1 million patients, showing that for the vast majority of cancer types, time to treatment is critically important. I would submit to you that it is the same for lung cancer. So what we've had to do over the past few years is kind of adapt our strategy in terms of pulmonologists to optimize efficiency and make sure that we start thinking from the end. When we have a patient with a suspicious lung lesion on a CAT scan, we need to think, could this be a cancer? If so, what kind of cancer could it be? What stage could it be? And start thinking, how do we optimize things? We get the PET scan, the MRI, we get the biopsy, the EBUS comprehensive staging, and we make sure that we get adequate tissue for next-gen sequencing, all in parallel, not in sequence, which adds up and prolong time to treatment further. So diagnostic evaluation, staging, and next-gen sequencing is what I'm going to be talking about next. I'd like to talk a little bit about the role of bronchoscopy in establishing the diagnosis. Over the years, there's been an ongoing debate about whether a patient with a suspicious peripheral lung lesion should have a CT-guided biopsy or a bronchoscopy. And the answer is yes to both, depending on what the presentation of the patient looks like. These techniques are complementary, and often patients are better suited for a CT-guided biopsy. Some are better suited for navigational bronchoscopy. What is clear, though, is with navigational bronchoscopy, there seems to be less complications and the ability to stage the mediastinum in the same setting. So that, in my opinion, should be preferred if both are options. Bronchoscopy has changed a lot since I became an interventional pulmonologist 15 years ago. This is what it looked like then. This is what it looks like now. This is a picture of one of my colleagues. I mean, she looks like she's in a spaceship. There's a robot, there's cone beam CT, there's multitudes of screens and adjunct technology that we did not have just a few years ago. And the question is, well, did this really improve our diagnostic yield? This is a very intriguing study that came out a couple of years ago in chest by George Silvestri and his group at MUSC. They looked at 126 studies, 39 before 2012, 87 after 2012, over 16,000 lesions overall. And the diagnostic yield did not seem to change. And so there was a big question about, have we really improved in terms of technical capacity? And the answer is we probably have. There's a lot of variation in estimates of diagnostic yield in this study, various definitions that have been used, very few RCTs. And importantly, I think what this meta-analysis misses is that we are going after smaller and smaller lesions with more and more accuracy. How do I know that? We do have data. We don't have a lot of RCTs like the previous speaker mentioned in oncology. We have a few. This is one from our lab that was just published in the New England Journal of Medicine a couple of months ago, which looked at modern bronchoscopy with intra-procedural 3D imaging compared to CT-guided biopsy. So these were nodules 10 to 30 millimeters, and they had to be amenable to both bronchoscopy and CT-guided biopsy. So we had a central adjudication panel that reviewed all these cases with an interventional radiologist and an interventional pulmonologist who were independent from the care team and made sure that these patients were candidates for both procedures. And then these patients were randomized to CT-guided biopsy versus bronchoscopy. And you can see that in terms of diagnostic utility, it's pretty much a wash, 79% for navigational bronchoscopy, 78% for CT-guided biopsy. Now, the 78% is much less than what's been reported in literature on CT-guided biopsy, but arguably navigational bronchoscopy is also much less than what other people report in non-comparative single-arm observational studies. This was a multi-center study with 7 sites, including both community and academic centers. What was very different is the number of complications, about 30% for the CT-guided biopsy arm versus 5% for navigational bronchoscopy. This was obviously very much driven by the rate of pneumothorax. If you look at pneumothoraces that required chest replacement or hospitalization, it was still very significant, both clinically and statistically. So my conclusion from this study is that with the data we have available right now, patients that are more suitable for CT-guided biopsy should get CT-guided biopsy. Those that are more suitable for navigational bronchoscopy should get navigational bronchoscopy. If both options are available, I think modern navigation bronchoscopy is going to become the standard of care. Role of bronchoscopy in mediastinal staging, that's one advantage of bronchoscopy, is that we have the ability in the same setting to interrogate the mediastinum and the hilar regions. We have a lot of good data on EBUS. And what's important to consider is that staging the mediastinum should be done in the majority of patients with resectable lung cancer. An estimated about 68% of patients should have some type of minimally invasive mediastinal staging before their treatment. The first study that established really EBUS as an unavoidable option, I think, for mediastinal staging was from Wallace and colleagues at Mayo Jacksonville, published in 2008 in JAMA. They looked at a combination of EBUS and EUS and found that the combination had a sensitivity for malignancy of 93% and a negative predictive value of 97%, which was remarkable. This was a non-comparative observational study. We have hundreds of studies on EBUS bronchoscopy, but 2 important trials, randomized controlled trials that were published in the past 15 years. The AstraZeneca study looking at mediastinoscopy versus the combination, again, of EBUS and EUS, followed by mediastinoscopy because that's what the guidelines recommended at the time, and the RRB in the Dutch team hospital that conducted the study required them to have mediastinoscopy, showed that with the minimally invasive approach, 94% of sensitivity versus 79% for mediastinoscopy by itself. A couple of years ago, the MEDIAS trial was published with 360 patients with negative EBUS and EUS. These patients were, 360 patients that were randomized to either EBUS, EUS versus mediastinoscopy, and EBUS, EUS was non-inferior to mediastinoscopy. So this was the first randomized trial comparing the minimally invasive approach, endoscopic approach to mediastinoscopy. So I think we've got good data suggesting that the combination of EBUS, EUS as part of a comprehensive and systematic mediastinal staging approach is a good option for patients. Now, this is changing a little bit in the way we are approaching patients. We used to not care at all about N1 disease, or very little, except for patients that were not candidate for surgery and more suitable for SBRT. We have to do this more comprehensively and systematically now because of the data on neoadjuvant therapy in particular, but also because of the new staging classification, which subdivide N2 disease into N2A and N2B based on whether there's a single node involved or multiple nodes. And so that's very important and has implication in terms of how we do this EBUS, EUS staging. I would point out that all these data really consider EBUS in combination with EUS, EUS being done in the vast majority of studies by interventional pulmonologists, whereas I think the majority of pulmonologists at this time do EBUS without necessarily considering EUS. Chest published a few guidelines in the past few years on lung cancer. One on EBUS in particular that I wanted to mention was that if you're going to do EBUS, ROSE is suggested. There seems to be a trend toward better diagnosis and better acquisition of sufficient tissue for next-gen sequencing using rapid on-site evaluation. That's an area of intense debate. The size of the needle doesn't seem to matter too much. There's a question of how many passes we should do if we're going to do EBUS. We should do at the very least 4 or more needle passes. That's based on very low level of evidence, but very strong opinions from the panel members. I would point out that we have for EBUS the same kind of problem we have for mediastinoscopy. If EBUS is not done correctly, then it's kind of pointless. And so this is a very kind of intriguing study looking at EBUS done by interventional pulmonologists that went through a formal interventional pulmonary training versus general pulmonologists and pulmonary fellows. The more training, the better the EBUS, the better the EBUS, the better the outcomes. And so I think it's important that for those of us who do this, we do this well and comprehensively. Finally, I'll mention the role of bronchoscopy in optimizing specimen acquisition for next-gen sequencing. I already alluded to that. We have quite a bit of data. This is a nice systematic review and meta-analysis published 3 years ago now, 21 study, quite a few patients. The diagnostic yield for next-gen sequencing was 86.5%. I would point out that there was quite a bit of variability with a high I-square with sufficiency estimates ranging from about 50% to 98%, so quite a high range. Nonetheless, I think this is reassuring data that EBUS is in the majority of cases able to provide sufficient material for next-gen sequencing. In terms of number of passes, they did this nice meta-regression analysis as part of this systematic review, showing that after 6 passes, we start plateauing in terms of acquisition of tissue sufficient for next-gen sequencing. So 6 passes seems to be the right number, despite what I just said about the guidelines specifying 4 passes. 6 passes is probably what we should do. Importantly, this was independent of all the other variables they considered. Now, there's something I need to point out with this study, is that most studies look at how often the next-gen sequencing results are coming back after the specimen are sent to Foundation or Tempus or other providers. What these studies tend to not look at is how often pathologists look at the slides and decide that the material is not going to be good enough to be even sent. When you look at that, and there's not a lot of studies that have made that distinction, the results are maybe not quite as good. So this is a study from Wake Forest that got published last year. In terms of next-gen sequencing, we were about 57% for EBUS, so not nearly as good as the 98% that I mentioned earlier. It was better with more than 3 passes, not quite as good for less than 3 passes. This is, by the way, what we have at Vanderbilt when we reviewed our data. So this is a bias in these mostly retrospective studies that is very important to consider in this study. We're running a multi-center randomized control trial right now looking at EBUS cryobiopsy. So that's a new kid on the block using the 1.1 millimeter cryoprobe. So this is a probe that freezes tissue, allowing us to pull fairly large chunks of lymph nodes to see if this may improve that sufficiency rate for EBUS bronchoscopy. Okay, so this was the outline. I went a little fast. I wanted to make sure I was staying within my time window. We talked about the rise of the oncopulmonologist, and then we talked about the triple goal for bronchoscopy, including establishing the diagnosis, making sure that we do a comprehensive mediastinal staging, and optimizing specimen acquisition for next-gen sequencing. Thank you very much for your kind attention, and thank you for inviting me.
Thank you so much, Dr. Maldonado. What a great presentation. So now we're going to move into our third and final speaker, Dr. Matthew Bott from Memorial Sloan Kettering Cancer Center, who will be giving us the surgical perspective, the surgeon's role in multidisciplinary lung cancer staging and team-based planning. Go ahead, Dr. Bott.
Hi, good evening, everybody. I'm just going to pull my slides up here. All right. You all can see and hear me?
Yes, Dr. Bott, you're all good.
All right, perfect. All right, my name is Matt Bott. I'm a thoracic surgeon at Sloan Kettering. I was asked to give some thoughts about the surgeon's role essentially in multidisciplinary lung cancer care, and in particular team-based planning. I'll talk a little bit about the potential surgeon's role in staging and diagnosis, and then as we move into sort of multimodality therapy, where we can play a role there. So just a quick overview, I'll give some background, and then, like I said, talk about surgeons in the setting of diagnosis and staging, some staging techniques and strategies that may be unique to surgeons. Dr. Singhi gave a great talk about systemic therapy in the context of surgery, so I can be fairly brief in terms of multimodality therapy, and there I'm really referring to either preoperative, adjuvant, or perioperative systemic therapy in conjunction with surgery. A few considerations when we think about how to plan those treatments for patients, and then I'll show you some data about the potential value of working in multidisciplinary teams. So I tried to frame this talk around some of the expert consensus guidelines that we had put together as part of an AATS panel a year or so ago. And, you know, probably the most important takeaway from the talk, which I think everyone has really stressed at this point, is it's really critical to accurately stage patients prior to initiating treatment, and that staging involves both lymph node evaluation as well as molecular testing, and that's clearly encompassed in these expert consensus document that I will refer to throughout the talk. So you heard Dr. Maldonado give a great talk about how interventional pulmonologists really play a vital role in diagnosing and staging the patients. He showed a roadmap to care that looks very similar to the one that I put together here. And I would just point out that you know, we work very closely with our interventional pulmonology colleagues in terms of a very robust diagnosis and staging program. And you know, I think along the course of this road, there are potential roles for surgeons throughout. You know, we, in addition to our pulmonology colleagues, we can also do biopsies these days with robotic bronchoscopy. We can perform mediastinal staging, be it endobronchial ultrasound or sometimes even surgical staging in terms of mediastinoscopy or other techniques, and treat the patient as well. Surgical resection, obviously, as part of their care. Perhaps the sort of ultimate integration of this would be something like a single anesthetic procedure. There are ways of doing this now in terms of biopsying with navigational bronchoscopy, performing endobronchial ultrasound to stage lymph nodes, and then perhaps resecting the patient all in the same anesthetic. I will say this is probably not widely in practice yet. I think the sort of interest in this is growing. There are some groups that have written about this. One of those is the group at Cedars with Dr. Sarkeesian. And this is a small study they had published a year or so ago, about 40 patients, really showing that it does, as you might expect, cut down on the time from seeing the patient to getting them resected, as well as some potential cost savings. I will say there are some sort of logistical and patient care challenges with this type of approach that I don't necessarily have time to go into during the talk today, but just a sort of way of emphasizing the potential surgeon's role within the care pathway. The other thing, I guess, is that there are surgical staging procedures that are really unique to surgeons. Mediastinoscopy, obviously, being maybe the most well-known of those, although I do think, as Dr. Maldonado pointed out, the role of mediastinoscopy has very much diminished in the current era of endobronchial ultrasound. You know, that being said, it does remain an option, particularly in cases where perhaps the endobronchial ultrasound was uninformative for one reason or other. I also wanted to touch on cryobiopsy. I think that's an important technology for surgeons to appreciate. So these are generally biopsies that are performed essentially through the working channel of the bronchoscope, where you put a freezing probe in, freeze the tissue, and then withdraw it through the scope. And it does allow you to get chunks of tissue that can be evaluated for architecture. So, you know, I think in a previous era, maybe where we had to do a mediastinoscopy to get samples of lymph nodes for lymphoma architecture or granulomatous disease. A lot of that now can be done more minimally invasively with this type of technology, and this has been very much embraced, I think, by our pulmonology colleagues, and something I think for surgeons to consider as well. Every time I give a talk on robotic bronchoscopy, which is one of my areas of interest, people ask if every lung nodule needs to be biopsied prior to resection. And obviously, as surgeons, we feel like there is a potential role for excisional biopsy in the diagnostic setting. I will say that this is generally suited for lesions that are amenable to wedge resection, small peripheral tumors where the likelihood of lymph node involvement is quite low. I'm referring here again to the expert consensus document, which does state that in regard to anatomic resection, particularly lobectomy, it would be strongly recommended that a tissue diagnosis is obtained before a procedure like that. I know there are folks out there who feel strongly about a diagnostic lobectomy being an option in some instances, and that may be the case, but I think it would be preferable to at least make an attempt to biopsy the lesion. I think there are some other sort of unique circumstances that I wanted to touch on where surgeons may play a vital role in the workup of patients in regard to diagnosis and staging. So I think, for instance, this situation where we see involve, let's say, AP window lymph nodes, level 5 in particular, that's an area I think that's difficult to reach. We have written a paper about biopsying that via robotic bronchoscopy. Others have done the same, but I think in routine practice, many times that's a surgical situation. This is a patient from my own practice, a 66-year-old never smoker who had a very small left upper lobe nodule and then had these PET-avid nodes. And I did, because of his risk of his likelihood of a targetable alteration was quite high. We did a thoracoscopy, dissected the nodes, found he did have an EGFR alteration. We did give him some preoperative therapy and then took him for formal resection later on. Again, I can probably go through this pretty quickly, given that Dr. Singhi covered it in quite a bit of detail, but safe to say that the multimodality options for treating patients with locally advanced lung cancer are numerous these days, and the systemic therapy space has really evolved quite a bit and become quite complicated. In an effort to sort of simplify that for the talk, I would say that the main takeaway, like I mentioned, really is that accurate staging and in particular lymph node evaluation and molecular testing really does help us select optimal therapies for patients in this situation. And for surgeons, I think what it sort of boils down to is that if you identify patients with positive nodes or larger tumors in general greater than 4 centimeters or so, then we want to consider the molecular testing. If they don't have targetable alterations, we would treat them with something like chemoimmunotherapy. I'll talk about that a little bit later. And then the landscape in the targetable therapy realm, which Dr. Singhi also mentioned, I think is very much in flux, and I'll touch briefly on that in a few slides. So Dr. Singhi also mentioned some of the potential benefits and drawbacks of neoadjuvant versus adjuvant versus what we would consider perioperative therapy, pre and post-op. Neoadjuvant, we give the systemic therapy earlier. We can eradicate micrometastatic disease. Patients are healthy at that point. They can generally tolerate the treatment. In terms of adjuvant treatment, if we skip the neoadjuvant treatment, we get patients to surgery faster. We can get pathologic information from their tumor, and we can potentially avoid delays to surgery or more complicated operations from preoperative treatment. And sometimes by combining those, we can get a potentially additional benefit from the systemic therapy, and also incorporate some surgical information in terms of tailoring that treatment to the patient. So in regard to perioperative therapy in the EGFR and ALK wild type setting, again, recommendations from the expert consensus panel suggesting that in patients with stage 2 and 3 disease who do not have EGFR and ALK alterations, platinum doublet chemotherapy with immunotherapy is preferred, and we would rather give that treatment up front in the neoadjuvant setting rather than adjuvant for the reasons that Dr. Singhi had mentioned. There are multiple, as he mentioned, FDA-approved regimens, either preoperative in the case of Checkmate 816 or perioperative with the studies that I'm showing here. The questions always come up, and he touched on this well, who gets the adjuvant portion of perioperative therapy? And there's, I would say, little data to guide us here. This is a post hoc analysis by Patrick Ford looking at patients from the Checkmate 816 study, which was the neoadjuvant approach, versus the Checkmate 77T study, which was a perioperative approach with the same medications, showing that for patients with a pathologic complete response, there really wasn't much additional benefit from the adjuvant portion compared to those with no pathologic complete response who did show a potential benefit to adjuvant treatment as well. How about adjuvant therapy alone? So in my mind, those are patients who have clinical stage 1 disease that are then upstaged at the time of surgery, right? Again, if we identify nodal disease or larger tumors preoperatively, we'd much prefer to give those patients, again, in my opinion, preoperative systemic therapy. I do include, as he mentioned, the FDA-approved adjuvant regimens, either chemo and atezolizumab versus chemo and pembro here. We differ maybe a little bit in terms of the targeted therapy approach. Again, I think this is an area that is very much in flux. This is data that my colleague Jamie Chaff presented at ASCO this year from the NeoAdora study. That was a study looking at either osimertinib plus chemotherapy or chemotherapy alone in the preoperative setting. And the takeaway is that the groups that got osimertinib, both with chemo and without, had a much higher rate of major pathologic response, about 25% or so, compared to only 2% in the setting of chemotherapy. So it sort of remains to be seen how this will be incorporated into guidelines. Will OC be recommended in a neoadjuvant setting? Will it be surgery up front and then adjuvant therapy after? I think all things that we'll need to wait and sort of see where the standard of care goes. ALK alterations, again, upfront surgery is certainly an option. Chemotherapy for a neoadjuvant approach is reasonable as well. Some of our oncologists do actually use alectinib upfront due to its potential greater efficacy, but again, not necessarily considered standard of care at this point in the absence of data. Adjuvant treatment he discussed quite nicely. Again, in terms of for ALK-positive patients, the ALINA study suggests a benefit to adjuvant alectinib and ADORA, similar data. I'm just showing you disease-free survival for the ALINA study and overall survival, which was recently published for the ADORA study on the right. So I was asked to talk a little bit about team-based treatment planning, and I think this is a concept that's really important. You know, I think as we consider treatment of patients with fairly advanced disease, resectable but advanced disease, a lot of things come into play. The anatomic extent of the disease, is it a big tumor? Which nodes are involved? How bulky are they? Are there additional sites of metastasis or potential metastasis? How much resection would be required? Histologic variables, type of tumor, presence of mutations, PD-L1 expression, and then the fitness of the patient. How old are they? What's their performance status like? What's their likelihood of perioperative morbidity? And perhaps the best place to put all those things together is within the context of a multidisciplinary team made up of many of the representative specialties within this webinar. There is actually data to suggest that patients treated within the context of a multidisciplinary team do better. I'm highlighting a couple studies here, which I would encourage you to review. I think also that we occasionally encounter this concept of borderline resectable patients, and I think this is an area of particular value within the multidisciplinary team. Questionable resectability can be for medical reasons. Patients may not be fit enough for surgery or have comorbidities. It can be for technical reasons. Maybe we're not sure that we can get an R0 resection. I think this is a little bit of subjective, maybe from one surgeon to another and one center to another, so it's hard really to study and clearly define. But we do know, as Dr. Singhi mentioned, about 20% or so of patients in the randomized trials of preoperative chemoimmunotherapy did not actually proceed to surgery. So that's important to bear in mind. I do think the multidisciplinary team can be particularly valuable in this setting, especially if surgery is ultimately not feasible. I did just want to present some data from a recent study that we were part of. This is a multi-institutional retrospective study in patients with borderline resectable or unresectable stage 3 lung cancer, generally patients either with a T4 disease or N2 or N3 lymph node involvement. Many of these would have been treated really within the context of a multidisciplinary team, like I mentioned. The vast majority of these patients, after receiving their preoperative chemoimmunotherapy, did actually proceed to surgery, about 75%, and over 95% of them did have a complete resection, suggesting that this approach in well-selected patients is feasible. We did notice that higher response rates were associated with those patients undergoing surgery, suggesting that ones that responded better were ultimately deemed fit for surgery. So there is a sort of imperative on our part to select patients who we think will potentially respond well for this approach. And in terms of doing so, there were several clinical pathologic factors within the study that were associated with a response, in particular pathologic complete response, things like smoking history, PD-L1 status, tumor mutation burden, and several particular genotypes, particularly in regard to KRAS, STK11, and KEAP1. Again, I think all of those things, putting everything together, surgeons, pulmonologists, medical oncologists, pathologists, really to select optimal treatment for patients in challenging cases. So in summary, I would say that staging and diagnosis, particularly including lymph node evaluation and molecular diagnostics, are critical in order to select optimal treatment for patients with resectable lung cancer. I think surgeons are an important part of the preoperative pathway and really must be familiar with modern diagnostic technology and treatment paradigms. Multimodality therapy has evolved rapidly and become quite complex, I think, with more changes, potential changes on the horizon. And then multidisciplinary teams really are critical for tailoring treatment approaches to individual patients and hopefully providing optimal outcomes. So with that, I'll finish, and I look forward to the panel discussion.
Thank you so much, Dr. Bott. That was a great presentation. At this point, I would like to welcome our presenters back into our discussion for our panel discussion section. So I have a few questions I would like to ask you. I don't see anything from the panelists per se, from the chat. So I'm going to start with some questions to see if that stimulates some conversation. So whenever you're having a multidisciplinary conference, I wonder what is you guys' opinion in terms of how you approach cases where imaging and tissue sampling don't seem concordant. What would you do in that situation? What type of strategies would you suggest? Maybe Dr. Bott can start.
Yeah, thanks, Dr. Bostock. Yeah, I think those situations are always challenging. I mean, I think uncertainty is always disconcerting, and both to providers and to patients. And I think again, the major emphasis on this webinar has been good tissue acquisition, right? Reliable biopsy specimens. And I think if there's a situation where you're suspicious about a disease being more extensive than it might seem, then taking some time to really sort that out is beneficial. And sometimes that involves additional surgery. Maybe you need to, wedge a contralateral lung nodule to decide if it's metastasis or something along those lines. But I do think really clarifying to the extent that you can prior to initiating any treatment or choosing a treatment course for the patient always seems to be a better approach in my opinion, but I'm certainly open to the others' thoughts as well.
Yeah, I'll chime in from the medical oncology perspective. We are obsessed with tissue, so thank you to all of our colleagues that get it for us. We really want to understand the staging before we get started. We really want to get the molecular profiling, and so often tissue is the issue. So yes, unfortunately, patients sometimes do need biopsies, additional biopsies, trying to get that information and clarity. I really try to stress that to patients that it can be imperative in trying to figure out their plan and really making sure we go in with a precise plan before we get started, right? So we can have hopefully better outcomes for patients.
And along those lines, maybe Dr. Bott, can you get Dr. Maldonado, I think, had to leave, but I'm wondering if you have specific strategies that you ensure to make sure that you have adequate tissue for both diagnosis and molecular profiling when you do robotic bronchoscopy or any diagnostic procedure?
Yeah, I think it's always a little disheartening when you feel like you did a good procedure and then for one reason or another there's insufficient material to do the extent of the testing. I think he touched on a little bit of it during the talk. If you're doing an EBUS FNA, then doing 4 to 6 needle passes, like he mentioned, I think is always good. We always assume that larger needles are better, but the data actually says the opposite, where a 21 or 22 gauge needle oftentimes is superior to, let's say, a 19 needle. I do think that it's in our interest to become familiar with additional biopsy technique. The pulmonology space is very excited about cryobiopsy these days, and I think few surgeons really utilize that. So, we're becoming more involved in that space as well, just because I do think it adds some value. So those are really the things. And I think the other thing oftentimes, maybe this is sort of directly or indirectly related to your question, choosing the appropriate site for a biopsy, I think is really important, right? If you suspect the patient to have metastatic disease, then biopsying the metastatic site is really the best way to ensure that, right? Sometimes we have to make guesses about whether something is metastatic or not, but I see sometimes where lesions we think are metastatic sites end up being benign, and we might be depriving patients of potentially curative therapy. So I would just caution folks about, really selecting their sites appropriately as well.
And then maybe, Dr. Singh, I have a question for you. When you're seeing a new patient and you are facing this issue with getting both a diagnosis, but also the whole workup in terms of biomarker testing and everything you need, how do you balance in your practice the urgency to move forward with treatment against the time required to complete the staging and molecular profiling process?
Yeah, Dr. Bostock, that's one of the hardest things, right? Telling a patient they've just been diagnosed potentially with cancer, they have suspicion for cancer, and then we tell them, you got to wait. We got to wait for the testing. We got to wait for the staging. We got to wait for the profiling, a lot of waiting. So I try to explain the importance of why it's so significant to wait, whether it opens doors for clinical trials, whether it opens doors for neoadjuvant therapy, whether it opens doors for really truly taking them for upfront surgical resection and feeling confident that afterwards we have an adjuvant therapy for you. So I think just as important as explaining why we need to wait is also explain to them the timeline of how that looks. And you're right, it can take, for comprehensive NGS, almost 2, sometimes 3 weeks to get those results. With advanced stage disease, we're trying to move and expedite testing for our patients by doing things like liquid biopsies. As I explained during my talk, liquid biopsies, the sensitivity is just not there yet for very early stages of disease, particularly like stage 1B disease, or if you don't have lymph node disease, you can't be truly confident if you come back with a negative liquid biopsy. So unfortunately, we do have to wait, but there are opportunities to try and expedite results, continue to improve our assays that we have for patients, and then make sure the multidisciplinary team is plugged in pretty early on to keep moving forward for patients.
And I have another interesting question for Dr. Bott that I thought maybe this is a personal conundrum for me, is that when we're considering all of these perioperative, neoadjuvant, adjuvant strategies for patients, often we're starting to see referrals for these patients with stage 3A or that in a more borderline performance status category, maybe an octogenarian, maybe somebody that doesn't have a specifically a particularly long kind of the length of life that you could estimate. In those patients, let's say like a 2B in an 85-year-old, what is your thought? Should we go straight to surgery and then consider adjuvant only if the performance status is okay, or just do surgery or do a neoadjuvant approach?
Yeah, I think those scenarios are always really difficult, and I do think those decisions are best made within the context of the multidisciplinary team. I can say that there's maybe been 1 or 2 instances where I've done sort of upfront surgery in that scenario, but I would much prefer to give the patient some amount of systemic therapy prior to surgery. And I think from a fitness perspective, that's always something that's hard to judge. Sometimes people look okay going into their systemic therapy and they really take a hit and then they're not candidates for surgery anymore. I have a paper in press really trying to sort out who those patients are, who's at risk for not proceeding to surgery. And one of the things that came out of that was age. So I do think that, you know, there are certainly things that we can consider when we're planning treatment for patients that may suggest a slightly perhaps alternative approach. But I agree, it's a really difficult area.
And you know, to just add to the discussion, we looked at our local data on patients receiving kind of a checkmate regimen for stage 3A, and what we noticed, you know, the paper talks about an 18 to 20% failure to get to surgery rate, and that's not what we were seeing in real life. So to be a bit of a devil's advocate, we were seeing less than 10%, maybe I think 6% is what we saw. People didn't progress to get their surgery, so it seems like these therapies are pretty well tolerated.
Yeah, again, I think it very much depends on what your sort of willingness to attempt that perioperative approach is, I guess. I think when we looked in our study, it was similar to what we saw in the randomized trials. So I think some of it is, you know, are you more inclined to treat a patient with, let's say, definitive chemoradiation if they're borderline, or a lot of times there's this kind of sentiment of, well, we'll give them some chemoimmunotherapy and kind of see how it goes, that kind of thing, which I think is not optimal for sure. But, you know, with all the enthusiasm around these treatments now, I think it's almost unavoidable to some degree. But I did want to just point out some comments in the Q&A. Eric, there's a question about if you ever have issues getting third-party payers to cover NGS for stage 1 cancers. And I guess the other thing is the squamous as well, right? If there are few actionable alterations, do you ever get pushback from payers about that?
You know, I think a couple of years ago I did. I was historically still even a few years ago doing this, ordering NGS testing for patients, regardless of their stage, if they had non-small cell lung cancer, regardless of squamous or non-squamous histology. Because even with squamous histology, I have several patients myself, either adenosquamous or squamous, where we do find an actual genomic alteration, and it does impact their prognosis. It impacts their opportunities to receive targeted therapies. So what I'll say specifically for stage 1 disease, there's absolutely an indication to get NGS. We have approvals for EGFR targeted therapy and for ALK targeted therapies for stage 1B disease. There are even tumors that were around 3 centimeters that were included, right? So for 3 centimeters, we need to even be thinking about systemic therapy. So if you get that pushback, I would encourage you to push back as well. Appeal it. Help support your patients. A lot of platforms that are improving and allowing for testing for patients are also stepping up to help offset those costs. So there are definitely pair programs, and there's definitely ways to appeal, but I would not let that stop you from getting information for your patient.
And to add to that, the results of like something like the risk reveal study, which is so interesting, right? How they took stage 1 patients, and then they were able to classify them into risk categories and show a difference in survival for those that had high risk that normally wouldn't necessarily get adjuvant treatment.
Yeah,
Definitely. And then, I don't know, Ian, do you want to address the other question in the Q&A?
Yeah, there's another question that says, how do you approach patients with a single mass and a single brain met? Do you still resect and proceed with systemic treatment? The patient has no ALK or EGFR mutation and has a high PD-L1. Does management change if she has an EGFR mutation? It's a good
yeah,
question.
start talking about this one, you know, this concept of oligometastatic disease, right? And what are we doing? When do we think about the role of LCT, local consolidative therapy, whether it's a patient with an actual genomic alteration, whether it's a patient without one? You know, at our institution, MD Anderson, we seem to be pretty aggressive about considering and talking about LCT for patients. My focus is really on treating patients with young onset lung cancer. So majority of my patients are actually under the age of 50. They're young. They have a great performance status, many of them with actual genomic alterations, many of them sometimes with oligometastatic disease. And in those cases where they're deriving a nice response from systemic therapy, if it's consistent with their goals of care, to have a discussion about the role of LCT, whether with surgery, whether with radiation, I think that patients deserve to be able to have that conversation. We all know that not all stage 4 diseases are exactly the same with regards to their presentation, with regards to their response to systemic therapy. So I think it's an open conversation. I'm curious, you know, Dr. Bod and Dr. Bostock, what you guys are doing at your institution. Is it an open door to have a discussion? What are your thoughts?
Yeah, I think, you know, we've been doing this, I think, more and more. And we, I think, like you, would prefer some course of targeted therapy prior to deciding whether they're really fit for local consolidative therapy or not. So in the scenario that was provided, let's say tumor in the lung and a brain met, we'd probably put them on treatment for some period of time. And Dr. Singh, I'm curious to hear what you think is the optimal period of time. I know it's a little debatable. And then consider them for local consolidated. Would we give radiation to both sites? Would we give SRS to the brain and resect the lung? I think all those things are, sort of choose what you like. It doesn't really necessarily matter quite so much, but I do think in a scenario like that, we would try and be pretty aggressive as well.
I would echo that. I think at MCI, where I am at the Miami Cancer Institute, same deal. So multidisciplinary management is the most important for decision making, right? And the perspective of adding some things into the mix. The question mentions PD-L1 expression. Well, if that's more than 50%, that's going to motivate everybody to consider treatment upfront. Performance status. If there's a single site, how motivated is the patient? What's the PFTs? All those things weigh in on how aggressive we're going to be. But if I were faced with that patient tomorrow, I think I would recommend some sort of upfront chemoimmunotherapy, maybe 4 cycles or something like that, followed by and often we treat the brain met first just to avoid a problem. So maybe radiation to that, and then surgical resection after that, and most likely adjuvant therapy. But that's at least just my humble thoughts, like Dr. Singhi would say.
Definitely. And Dr. Singhi, the duration of systemic therapy prior to local consolidative, does it differ between targeted therapy and chemo IO, or talk us through that a little bit? What do you think?
Yeah, I don't know if there's a perfect number, Dr. Bott, to tell you the truth. What I've been doing for a lot of patients, the biggest population that's been coming to me personally and to several of my colleagues is patients with EGFR positive disease, stage 4, oligometastatic, maybe polymetastatic, but have had an amazing response to therapy. When's the right time for them to come or seek out opinion to ask about LCT? I usually tell them if they're on combination therapy like the 402 regimen of osimertinib plus chemotherapy, after a platinum chemo is done, let's get a scan, let's have a conversation then. So really trying to maximize the response that they get out of their platinum therapy if they're on it. If they're on targeted therapy alone, usually no earlier than 8 weeks, probably closer to 10 to 12 weeks is when we'll have that conversation. That also proves to the biology, I would say, but also their performance status, if it's improving, and opportunities to really make sure their quality of life is optimized after their diagnosis, after starting systemic therapy. So no sweet spot, but that's just sort of my average.
Great. All right, great.
Yeah, I think standardizing these management strategies going forward is going to be really valuable, right? How do we treat brain mets? How do we treat mets to the adrenal gland? How do we treat like maybe 1 or 2 sites of like a bony lesion or something like that? Is going to be really critical as we move the needle forward. We gotta make sure that we're not doing crazy things and standardize our strategies.
Absolutely.
Well, I would like to really thank you guys for such great talks and for staying within our time frame, and so that we could have this wonderful discussion. I think we're at the end of our time, but thank you everybody for joining this STS webinar. It was my pleasure to be your moderator, and I hope that everybody has a great night.
Thank you so much.
Bye.
Thank you so much to our moderators and panelists for your participation and insight. And thank you to our sponsor, AstraZeneca. If you're not one already, we invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code right on your screen. It's almost time. Registration will open for STS 2026 in September. We're excited to see you in New Orleans. You'll enjoy a variety of discounts and benefits if you become a member and attend STS 2026. Find more information using the QR code on your screen, and mark your calendars for another upcoming STS webinar supported by AstraZeneca, updates to the treatment landscape in non-small cell lung cancer, adjuvant and neoadjuvant therapy. A lot of what you heard about today, plus more. So thank you so much. We hope you have a great night.